Welcome back to Mentors and Masters. Today I'm going to share with you the use of one of the most important tools in my toolbox, and it should be one of yours as well. There are so many advantages to using this instrument that I had to make a list, and it's so numerous I'm going to have to read it to you. It's just too much for me to remember in one whack. This outdoes everything else, not by just a little bit, but by an enormous amount. It's fast. There's typically no anesthetic necessary. It's essentially pain-free. It's minimal invasion for maximum adhesion of materials. There's no high-speed drill whine. There's no heat generated from a fast-spinning burr. There are no tooth odors from the cutting of a tooth. There's no fear generated in younger patients. And all in all, it's quicker, cheaper, and better. I'm going to go through some of the procedures that I do with this and share them with you because it's so significant. I'm still having a very difficult time understanding why many dentists are not employing this technology. It just seems so obvious to me. So stay tuned, here we go. This is an example of a failing sealant right here. It's probably a glass ionomer. It's completely gone over here if it was ever there. But we have an area of decay here. I'm not sure how big it is, but we're going to find out. No anesthetic yet, and we're going to take that out with air abrasion. We're taking it out the small area right here with air abrasion on a small needle point tip air abrasion, and we're taking it out over here. It was very tolerable, all these areas and through here. This one got quite deep and the patient got a little bit uncomfortable, but said to me it wasn't so uncomfortable that they thought they would need local anesthetic. There it is done. There it is finished with the composite in place, bonded in place. And this will probably last this patient because they're so small and they're so non-invasive and they're so well prepared for adhesion that they are not going to come out, and they're probably going to last without any decay around any of the areas, possibly for the life of the patient. But certainly this is 10 years on this already, so it's going to last a long time. It shows no level of change, no degradation at all. So this is one of the instruments I used for a long time. It's from Crystal Mark. It's a very nice instrument. You can control the powder flow, which is the aluminum oxide, which is very hard, and you can control or increase the air pressure for the tip of the instrument over here. It comes out on a little air tubing. You can use this intraorally very safely. You have to be careful that you don't point it at soft tissue directly. I mean, that's obvious. We're talking about hard tissue, hard teeth. This is the one I've used a lot, and this is from Danville Zest Dental Solutions, and this has a very small tip that's interchangeable and autoclavable. You can adjust the powder flow, and you can adjust the pressure of the instrument here. So you can control this, and the tips are very small. You have contra-angle and reverse angle tips, and a very small stream will come out of this, almost like a needle point. The tip here is very small, and the powder flow is very intense because it is so small. You can control the pressure, and you can control the amount of cut by the pressure and the amount of powder flow. It's not the powder flow that cuts the tooth structure or removes the decay as much as it is the pressure. This is a wider spray at the end of this instrument. It's very easy to control the amount of powder that comes out of this and the amount of pressure that comes out with the valve that's on the side of the instrument, and I'll show you that in just a moment. This is the micro etcher, and this is the one you can use intraorally. This tip comes off and you can sterilize that in the autoclave. These things take a little learning curve, which is also very short. I'll show you one that I came up with, and I recommend you trying this. Take an extracted tooth and air abrade the surface of the extracted tooth until it looks chalk-like chalk finish. And where it's soft, the air abrasion will go into the central grooves and into these fissures and into these little grooves and cracks. And you can very easily clean and clear this out. I was able to do that with the air abrasion. I total etched it, and I dried it off, and I put on Photobond, and then I put on this. Try that on an extracted tooth. You want to see what this stuff does? You want to see how powerful it is? Get an extracted tooth. I want to show you how powerful this is. This is an extracted tooth, and this is an area we abraded for 5 seconds with the microetcher tube. This is 10 seconds. We're clear through the porcelain now, and then we're going to go to the root surface. We're going to go 5 seconds on the root. It just clears it off. 10 seconds, it's clear through the root surface into the pulp chamber. You can get an idea from this little experiment, of this little trial, how powerful this technology is. One of the disadvantages along with mesh is that it does have the tendency that if you're looking in a mirror and doing something indirectly, it'll fog the surface of a normal mouth mirror, which costs about $4 from here up. And that surface, just from the ricochet off of the tooth onto that mirror, will fog that surface in 10 to 20 seconds. This is one that's sapphire mirror from Crystal Mark. This one costs $4 to $5. This is $150. This one lasts 15 seconds. This one lasts 5 to 10 years. It's worth the money. If you're going to do air abrasion, I think you should also get this mirror. You need dry air, and the new compressors have typically a water filtration and a water coalescent filter on them, or they will be dried with refrigerated dryers. But dry air is critical when you're doing adhesion dentistry. This is a very good compressor. It costs anywhere from $5,000 to $7,000. Well worth the money, because this is something that's important to you in your office. I knew I was going to use air abrasion a lot, frequently, on every procedure almost. So I put in a high velocity, high CFM, 350 cubic feet a minute on this. It's a dust collector from a commercial cabinet shop. It can be plumbed up to the foot of your chair, and this is the funnel that can be reached over here near the patient, and it's got this collapsible tubing that will collapse down into this PVC holder right there. The patient can then hold this near their face. You can also get these as standalone with a stiff hose or stiffened tube, and this can be placed near the patient's face as you're using this if you want to go to this extreme. Then the patient can hold it with they're using this vacuum right here near their mouth where you're going to be working and breathing oxygen. That's really extreme. That's for the person that's really concerned about the mess that this is going to generate. I find that most of the time I can just have my assistant hold a high velocity vacuum very near the area where we're using it, and it's plenty of vacuum to reduce the mess to a point where we can contain the mess. It is messy. That's probably the biggest downside. There are some foods you eat that are very messy. For example, a really juicy hamburger is messy to eat, but there's ways to control that mess, and that mess is not going to stop me from eating a great hamburger. This has been around. I've been using this for 35 years. This is definitely something that is well worth your time to do. I also plumbed the vacuum into the laboratory because I use it a lot in the lab. You can also use a micro cab, which is a vacuum system where you can put these small pieces into the vacuum cab, or you can use it in one of these drawer-mounted vacuums for dust collection. But if you're going to use it intraorally, you have to just be careful where you point it, obviously toward the tooth. The PSI on this instrument shouldn't be any higher than probably 65 to 75 pounds PSI. Any greater than that, you are asking for trouble and you bore a hole through the tooth too fast, or maybe accidentally hit something you don't want to hit with it. But it's not dangerous. It's not any more dangerous than any rotary instrument they would use on a patient. If you're going to use it, definitely use eyewear. Eyeglasses are essential. The more they cover the eyes and the better they cover the whole area that possibly could get a particle into the eye, the better off you are. Okay, you'll need also a good retraction to be able to get where you want to go. And using the Prep Start, now this is the one from Danville Zest. So this is the preparation with the Prep Start, and it's very fine tipped, and it will just remove the decay in tooth in this area only. It's a very minimal invasion instrument. We've got a situation here, and I don't know what I'm getting into. I know that this is going to be minimal, but I suspect it's going to be a little more than this one. So this will probably be a sealant, and this will probably be a class 1 composite, a very small one. This is the one that was in the back that was really minimal, but it turned out it was much deeper than that, and this one was as well. Now this took a little bit of local anesthetic, and within 3 minutes, this tooth was dull enough to where I could continue into this one deep area. The patient was not complaining. At this point, we're going to check this and make sure all of these areas that we've invaded with the air abrasion are clean and clear of decay and debris. So we're going to paint the area with a caries finder red. And if that all washes off and there's no evidence of any red on that tooth, I know it's clean. I can then use a total etch system, which is a liquid etch on a brush for 5 to 10 seconds, certainly not much more than that, 15 seconds at the outside. After that, you start actually decreasing your bond strength. Wash and dry and put in photobond, air thin that, cure it, and then place your flowable composite. I prefer the SRO, which is super radiopaque accolade, because I can put it into the tooth and cure it. It looks like this when we're done and polished, but I can also see that material on an X-ray. Very nice material because it's so radiopaque. It's a flowable composite that's radiopaque. I can do this much faster than using a block or local anesthetic and getting everything numb, and then going with a high-speed air-driven turbine handpiece and shaking and rattling the patient and generating heat and discomfort and pain. And it's just, with a well-trained assistant, I can do this in 35 to 40 minutes, okay? So this is a tremendous service for your patients. Again, I find it amazing that so many people don't use it. I'm just amazed when I talk to a dentist that doesn't have it in their office. It's just like, I have a hard time getting my mind around that, because for 35 years, I've used it routinely with tremendous success. I can't endorse this anymore. I did a very interesting evaluation of air abrasion by one of the shops in the local area. Does a metal preparation for a powder coating. You've all heard about powder coating. Well, they first use air abrasion on it to get it clean. This is a horseshoe we found in the yard, probably 75 years. It had a tremendous area of rust over here. So I took it down there and put some tape on this side and closed this all off so they couldn't hit it with the air abrasion. They sandblaster, and I asked him, can you just clean this for me? He said, yeah, I can do that. What do you want that for? So anyway, he did it, and this was the area that was air abraded and sandblasted, and this obviously is not. Well, let's look at these areas real close. We're gonna zoom in on that. That's what it looks like. There's a lot of contamination on that surface. When you look at that right here, and we zoom in really close, that is a contaminated surface, and that's what maybe some of you are trying to bond to intraorally on your teeth. If you look at this surface, this is clean and clear and pitted, and it has a lot of aggressive sand blasting on that that's got down to a clean, mechanically retention-like surface, okay? Now we're gonna try to bond to that surface. So I've got a little video I wanna share with you, and we're gonna just show you. I'm gonna use a composite that's a temporary composite auto cure. We're going to add it to the material. We'll hold it in the vise over here in the shop, and we're going to put a big blob right on there, and then we're going to stick a nail in it, and the nail will stick in that material. We'll let it set up, and then we're going to try to pull it off. So I've got a pair of pliers here. We're going to try to yank that off using the nail as something to grab a hold of, and bang, it just pops right off, and there's your contaminated area on that material, and the debond occurred at the material. It debonded from the horseshoe, okay? Because it's a contaminated surface. Here we're bending the nail back and forth until the material failed. It didn't debond. The material's still there. It just pulled the nail out. It broke the material. If we take a chisel and just tap that area, it's gone. Try it again. Just put a chisel there, tap it, bang, it's gone. Pick them up across the room, and it debonded at the horseshoe. Go back to the side we cleaned and air abraded sandblasted. You'll see that I'll have to chisel the material off. It's not debonding, it's not coming off at the surface. I'm actually just breaking the material off in pieces. It's coming off piece at a time. You can see the shadow of me pounding on it. It's really adhered to that. It takes about 5 or 6 blows before it starts breaking. What's going on here is the material is shattering. It's not just coming off in one lump piece and debonding from the horseshoe. So the demonstration is to help you understand how significant this is. This is not just something that somebody thought of that would be nice to do. This is essential in adhesion dentistry and everything you're doing that is minimally invasive and conserving tooth structure for your patient, that you can put something in and bond it to it, and it will stay there. It will adhere to it with tremendous tenacity. You can't chisel that off. So when you do that on a tooth, use air abrasion, you're prepping the prep, or you're doing the whole prep with the air abrasion. You're total etching the tooth. You can't rely on air abrasion just for the etch. You have to etch it with the acid as well, 37% phosphoric acid, from 5 to 10 seconds, maybe 15 seconds maximum. You do the etch with the acid, and then you wash and dry, extremely dry, photobond, and then your flowable composite, and you'll have a restoration for your patients that will last decades. It's extremely durable, no failures, minimally invasive, fast, quicker, cheaper, better, no pain, no heat, what else is there? We're just talking, this is it. I can't say enough about it. But anyway, thanks for listening. Stay with us. We'll be back with more from Mentors and Masters.